Welcome to Veteran Cancer Talk by the Veteran Cancer Network. I'm your host, Ashton, and today I'm joined by Dr. Elizabeth O'Donnell, Director of Multicancer Early Detection Clinic at the Dana-Farber Cancer Institute. Dr. O'Donnell, thank you for joining us. For listeners hearing the term for the first time, what is multi-cancer early detection and why is it gaining so much attention right now?
So first of all, thank you so much for having me. It's a great honor and privilege to be here. And so multi-cancer early detection is a new technology really of screening for cancer. So it's hard to screen for many cancers at once. Think about trying to go to your doctor and having a colonoscopy, a mammogram, a pap smear, an EGD, all these different tests. And so what's happening now in science is we're leveraging the ability to look within blood and other body fluids for fragments of DNA and other signatures that can help us identify cancer. So we couldn't do this 10 or 20 years ago, but it's pretty amazing science. And what it's hopefully giving us the potential to do is screen for the cancers that don't currently have screening tests.
So how are and for short, it's MSED test.
Yep.
How does that differ from the traditional cancer screenings that are happening now?
Yeah, so traditional cancer screenings actually are about 30 years old, the three that are recommended. So the current screening recommendations are for mammograms for breast cancer, for cervical cancer screening with pap smear, and then for colorectal cancer screening with colonoscopy and some of the other modalities. If you have a significant smoking history as well, then low-dose CTs are recommended for lung cancer screening. But all of these are either imaging or procedure-based. 70%, over 70% of cancers don't have screening tests. Coming up with validated screening tests, though, is challenging because the endpoint, the thing that the studies want to see, is that the screening test changes how long you're going to live, how it impacts your disease-specific mortality or your overall mortality. And so these studies take a long time to read out. And so it can be really challenging to get new screening techniques approved.
Mm-hmm. Now, the MSED is a single blood draw, correct?
So yeah, there's a lot of different types of MSED tests. The ones that are commercially available currently that have actually had clinical trials done and appropriate studies are blood-based.
Okay. And how many cancers are they able to detect at one time?
Yeah, so of the tests that are commercially available, the ranges can be anywhere from 20 to up to 50 cancers. Some types of cancers you could kind of lump together, in the GI tract or head and neck. But for example, there are two commercially available tests right now. There's Grail's Gallery test and Exact Sciences Cancer Guard. And the Gallery test will test for up to 50 different types of cancer. None of these tests do every cancer equally well. So the test does some cancers better than other. It also does cancers that are more advanced. It's more sensitive than earlier stage. Kind of the holy grail would be to find cancers at their earliest possible stage. And that technology continues to evolve.
Now, what exactly is the test measuring?
So there are actually different techniques that are being employed. If we look at the Gallery test, it's looking for what are called methylation signatures. So it's looking for pieces of DNA. So if you think about it, we first sequenced the human genome just over 2 decades ago. Now we know what cancer genomes look like, and we specifically know what each different type of cancer looks like. And then there are patterns, ways in which the genes are turned on and turned off by methyl groups. And so those are unique to each type of cancer. And so that test uses the technology to find the DNA and then see what the patterns are in it to identify cancer and to say what type of cancer it might be. Other technologies use other analytes as well and combine the modalities, similar to how we combine different chemotherapies, trying to achieve more efficacy. So, there are a lot of evolving techniques as well that aren't available to patients yet, looking at immune responses, changes in immune signatures as well. It's a pretty amazing field scientifically that's going on right now, and we hope that this will make its way into clinical trials and ultimately to patient care.
Mm-hmm. Now, is the MSED meant to replace the standard screenings, or will it be working alongside them?
Absolutely not. So it is meant to complement those. And I do want to be very clear that, these are not FDA approved. They're seeking FDA approval. They're doing clinical trials, but these are not vetted. They do not have United States Preventive Task Force Services recommendations. They haven't met the gold standards of disease-specific mortality the way the vetted ones that I talked about earlier have. So you would not replace those at this point with these tests, but you could add them.
Mm-hmm. So let's talk about how this technology is being studied specifically in veterans. So I know Dana-Farber is working with the Sentinel Study. So what exactly is that evaluating?
Yeah, so the Sentinel Study is a Department of Defense sponsored grant study that we're leading, looking at the use of MSED tests in the veteran population. So individuals who have served for more than 4 years in the U.S. Armed Forces or National Guard. And, there are a lot of concerns that veterans have increased rates of cancer. And so, to offer additional screening is the goal of the study, and to see if, in fact, these tests do pick up other cancers at earlier stages, a broader range of cancers. And what we've really tried to do is, one of the other kind of optimistic goals of MSED testing is that blood-based screening is easier, right? You can go and get your blood drawn, and if you are able to add that to what you're doing, it's a good way to kind of enhance your healthcare. So we think it's important to model that in our clinical trials. So we're using the GRAIL test and their network so that patients anywhere in the country, or people anywhere in the country, can enroll online, and then they can get tested locally. If they have a positive test, so these are screening tests. If you have a positive test, it does not mean you have cancer. It means you need additional testing. Then we have funds within the study to bring people to Dana-Farber if they want to come here. Otherwise, we'll work with them in their communities to find providers that can help them work up the result.
Mm-hmm. Now, who qualifies to participate?
The criteria for this study are active duty or National Guard Reserve military service for 4 years or more, age 45 years old or higher. And the most important criteria, though, is that you have to have received some care at the VA, at least one point of contact within the past 5 years. And the reason for that is that we're doing what's called a synthetic control, where we're comparing the number of cancers detected by this test in the study with what is seen in a matched population within the VA. So those are the key criteria: service of 4 years, age 45 or older, and it's seen at the VA at least once in the last 5 years.
Mm-hmm. Now, one area that our audience obviously cares a lot about is access, especially when it comes to age and screening eligibility. So at the Veteran Cancer Network, we advocate for lowering age barriers in high-risk veterans. Why do studies like Sentinel use specific age thresholds?
Yeah, so the age thresholds are set on the back. For the number one risk factor for cancer is age. And so when we think about screening tests and screening viability, one of the metrics people look at is the number needed to screen. And so when you look at the incident curves of cancer, the number goes up dramatically with age alone. And so the typical screening age is actually over 50, and that's what's been historically used in the clinical trials of MSED tests. So we did back it down to 45, but we're also really trying to identify the people who will benefit most in terms of the greatest number of people who might have a potential cancer. I think if we find that there is, a positive signal from the study that we're doing, from the 1,500 people that we're screening, then that would be incentive to really think and look back further into younger patients. But the reason is based on the fact that age is actually the greatest risk factor for cancer.
I know a lot of scientists are looking at a lot of the data and how that's going to influence, age recommendations. Do you think that future, data is going to change the screening protocols that are, maybe to a younger age?
Well, I think what we're seeing on a kind of a global level is a change in the age in which people are developing cancer. So on a large scale, whether it's the air we breathe, the water we drink, the food we eat, is influencing the rates of cancer in younger individuals. And so ultimately, that may well impact screening guidance. And we've already seen that, right? So we've already seen a change in the screening guidelines around colorectal cancer, lowering the age for colon cancer screening.
Now, let's say that a veteran is participating in the study and they receive an abnormal result. What happens next?
Sure. So our study team would reach out to them. I would reach out to them to talk through the actual result. So if you get the result of the test that we're using, it tells you that it's an abnormal result, and then it suggests what cancer it might be. And so someone needs to do a workup at that point to evaluate that signal. And so the study has funding to bring patients to Boston and to do that workup here, but we recognize that not everybody can just pick up and come to Boston. And so, I would work with the patient and find a local provider. What's actually been nice about this whole MSED community of providers is that, it is growing, and we have in anything probably like the military, we have colleagues all over the country. And, there are centers of excellence that are doing similar work to what we're doing, and we would make sure we found an appropriate person to help us do this workup.
Mm-hmm. How do you determine where the signal may be coming from with this test?
The test does it. So it uses that methylation pattern, and each cancer has a unique methylation signature. So, they have a proprietary AI algorithm that they use. But when you have the test, it will tell you yes, no, abnormal, and then it will suggest based on that methylation pattern and their algorithm what cancer it might be. And so when we do the workup for that cancer, we focus first and foremost on the cancer suggested. However, let's say we don't find a cancer, because that would be really worrisome, right? We know that there are false positives in these tests. And so we do two things. One, we repeat the test to make sure it was a true positive, and then we follow people long term, and we continue to do a little bit heightened surveillance to make sure that it's not just a false positive.
And how many false positives percentage wise, can one expect?
Yeah, so in the Pathfinder 2 study, which was the most recent study of the Gallery test, the positive predictive value, meaning if you have a positive test, the likelihood that you have a cancer is about 62%, which means that 38% of the time it's a false positive.
So, what are some of the current limitations of MSED testing that both patients and clinicians should understand?
Yep. So first and foremost, these are not a replacement for guideline recommended screening. And, the test itself, is not a guarantee that you don't have cancer. If something is a very early stage, and it's not as sensitive for every type of cancer. So I think you just have to recognize that these are tests that there's a reason we're using them in clinical trials, is we're trying to study these and understand them. To make sure, as they move forward trying to get FDA approval, that we understand the pluses and minuses of these tests for patients. But, if you do find, one of the limitations obviously is if you do have a positive test, it's not a guarantee that you have cancer. And so we have to make sure that we do a proper workup and also follow people long term.
Mm-hmm. Now, bringing this back to the veteran community on a more broader scale, veterans, as you have mentioned, carry an increased cancer risk due to toxic exposures, the food, et cetera. How might early detection tools impact that high risk population? And could MSED testing shift outcomes within
Yeah.
these groups?
So I think, the goal of MSED testing is to find a broader range of cancers, but also to find them earlier. And so, for most cancers, we don't have screening tests, and we wait for patients to develop signs or symptoms of that cancer, or sometimes they're just picked up accidentally. You're getting a scan for some other reason and they're found. And so for people at high risk, we want to be able to do heightened screening and potentially find cancers earlier while they're still curable. Cancer therapies have gotten so much better in the last 2 decades in particular, but we know that our best chance of curing people is still when we find cancers earlier. And so I think that's really the goal of MSED tests. I don't think that they're going to get it right on the first try. This is very much an evolving science. This is not a finished product. And so, I believe that there's value in supporting this work. It's a huge unmet need. I think most people in the military know that we try to prepare for everything. We try to be as proactive as we can in life, thinking about ways in which we can prevent bad outcomes. And so much of oncology has been treating cancers after they're diagnosed. And so for so long, and maybe it's because we didn't have the technology, we really didn't take a proactive approach to cancer. And for a lot of people like me, it just makes sense to take the same tools that we've used to do the research about drugs, but to do them for early detection means so that we can cure more people and find more people when the time is right to make sure we can best manage the disease.
Hmm. Now, zooming out from an individual study to a broader picture of oncology, if the MSED test is validated through the research, how is it going to change cancer screening models?
So, very importantly, there was legislation passed early in February. There was a bill that was had bipartisan support, the Nancy Gardner Sewell Act, which got passed, which creates a pathway for Medicare reimbursement. And so these are lab developed tests. It's a little bit like nuanced in all of this, but there's no Medicare reimbursement for screening tests of this type, and so this is a really important thing because it created a pathway where there needed to be one, so that if a test does clinical trials, proves its efficacy, it can get FDA approved, and then there's a pathway that Medicare can cover it. Why is that important? Well, it's great to have these tests, but they cost a lot of money. So if you were to pay for them out of pocket, they're $950. And that isn't at all, necessarily affordable for people. And so it's really important that there be a way in which Medicare can cover these so that people don't have to pay for them, so that their health insurance will pay for them. And that's how we broaden access to care, is having this opportunity for reimbursement.
Hmm. Now, outside of the reimbursement and the insurance, what would broader adoption mean for oncology practice and cancer research moving forward?
Yeah, so I think broader adoption would really be you have to have high quality studies that demonstrate that these tests do as they say they're going to do, that they find more cancers and find them while they're still curable so that you can actually improve patient outcomes. And we have to then, primary care is where cancer screening typically lives. I'm a medical oncologist and I'm a cancer researcher, but most of cancer screening occurs with your primary care physician. So there needs to be really the knowledge and understanding of how to use these tests, and a willingness of primary care doctors to take them into their practice, to get comfortable using them. These aren't really new skills. We're all trained how to do a cancer workup as part of our internal medicine training. But anything new just requires a willingness for people to learn a new test and take on a skill set. But the more broadly available, the better in terms of access. One of the things that I think is so critical is just being able to get to people who may not, whether it's rural, or whatever the factors are, you can't take time off work to get somewhere, having a test that can meet people where they are, where they live, so that they can get screened.
Now, I know a lot of people hear the word cancer or tumors, especially from, the caregivers and the person actually going through, the treatment. What would you tell them when it comes to getting that diagnosis, from a clinical perspective, to kind of ease their fears?
Yeah, I think cancer is scary. I mean, I think that that's, one of the things that is very common in America. We all know some loved one, some friend who has had a cancer experience. And so, the best thing that you can do to lower the risk of having, a bad cancer experience is to find it early, and to do testing, to take care of yourself, and to be proactive in your healthcare, so that if you do have a problem, the earlier we find it, the easier it is to address it. It's as simple as a stitch in time saves nine, in terms of how, if we can find things. It's not true of every single cancer, but for the majority of cancers, our best shot is when we find it early.
Wonderful. Well, Dr. O'Donnell, thank you so much for joining the show. Any parting wisdom for those in the medical community that are interested in the MSED and possibly implementing it in their studies?
I would just like to say that, this is an exciting and evolving field. We're really, I hope, at the start of a screening revolution, that's going to make cancer detection better for everybody. If there are any providers or any people who would like to learn more about the work that we're doing, or are interested in doing MSED themselves, I encourage you to reach out to me. We are, happy to try and help you, and also to help any veterans who are interested in being screened. And I specifically just want to conclude by thanking the veterans who are listening for their service to our country. Thank you.
And for those veterans that are interested in participating in the Sentinel Study, you can find all that information on our website, veterancannernetwork.org, or you can go to any of our social medias. We are going to be having this posted into the comments. But again, thank you, Dr. O'Donnell, for joining us.